free join club. Audio, is it coming? Hello, hello. What is सबमिट में कोई प्रोडक्ट्स दिखा रहा हूँ सर, पीपीटी चेक करवा दूँगा सर आपको भी. सर बढ़िया है. Very good morning to everyone. Moderator for today's Journal Club is Dr. Jasmita. Sorry for the delay in the start. There is a technical problem here. So the first article I have chosen is mutations associated with age-related clonal hematopoiesis in primary myelofibrosis patients with rapid progression to myelofibrosis. So this article was published in Leukemia in May 2020, and it was done by Stephen Bartels et al. So primary myelofibrosis is a myeloproliferative neoplasm with a cellular phase which can progress to either fibrosis or acute leukemia. And according to one study, 11.4% of myelofibrosis cases progress to fibrotic stage in 10 years as compared to 1.5% of ET cases. So this shows the heterogeneity between these two diseases. So this study was done by Lata Gliata et al. And currently there are various prognostic scores in myelofibrosis which include mutation enhanced international prognostic score for transplant age patients, and recently genetically inspired prognostic scoring system was also introduced, and we also have clinical scoring systems like dynamic international prognostic scores and international prognostic scores. So all these scoring system predicts poor prognosis in the form of survival, bone marrow failure, or development of acute leukemia. So we all know that the mutations like ASXL1, TET2, DNMT3A with allelic burden of 2% is frequently encountered in elderly individuals without any signs of development of hematological malignancies. So in such patients, the progression to overt neoplasia is around 1.5% per year. So these mutations without any development of hematological neoplasia is termed as clonal hematopoiesis of indeterminate potential or age-related clonal hematopoiesis. So the research questions here was whether the presence of these mutations can change the course of myeloproliferative neoplasms which have already acquired driver mutations like JAK2, calreticulin, or MPL. So if so, then which are all the mutations which are associated in development of myelofibrosis? So coming to the methodology, it was a retrospective cohort study done in Institute of Pathology in Germany. So they have taken the decalcified formalin fixed paraffin embedded bone marrow trypsin biopsies, and they had two cohorts. The first cohort of patients were fibrotic progression cohort, in which there are at least two bone marrow biopsies done, one at diagnosis and other was during follow-up, with a minimum follow-up period of one year. And the bone marrow at diagnosis should not have any fibrosis and should not have any excess blast, and the latest available biopsy had minimum of grade 2 fibrosis. So this was the inclusion criteria in this cohort. And the other cohort group was a cohort without fibrotic progression, in which at least two bone marrow biopsies were performed and a minimum of 4-year follow-up was given. And in this, again, the first bone marrow biopsy should not have any fibrosis, and also the last available biopsy should not have any fibrosis or excess blast. So in the cohort without fibrosis development, the reasons for performing follow-up biopsies were development of anemia, thrombosis, etc. And they followed WHO grading for fibrosis, bone marrow fibrosis, and IHC was performed on all cases, CD3, CD20, 34, 42, 117. So these are all the markers which were done in all cases. They excluded the cases which had other concomitant neoplasms and cases which developed acute leukemia. So the main aim was to study the fibrosis and not the leukemia part. So next they did nucleic acid extraction and then sequencing. So for this they extracted the DNA and NGS was performed. Along with NGS, they also analyzed the tumor mutational burden using the commercial Oncomine tumor mutation load assay, so which covers 409 genes with 1.7 megabase exonic coverage. So in NGS panel, they had 25 genes covered in this NGS amplicon based panel. So the sequencing data evaluation and variant annotation was performed using ANNOVAR software, and statistical analysis was performed using GraphPad Prism version 5. The tests used were two-sided Fisher exact test, two-tailed independent t-test, Mann-Whitney u-test, and they used Kaplan-Meier survival curves calculated using log rank test. And the results were considered to be statistically significant when p-value was less than 0.05. So coming to the histopathological findings, in the initial biopsies there was not much of a difference between the two cohorts, whereas the follow-up biopsy showed increased fibrosis and megakaryocytic dysplasia in the fibrotic group. So this is the histopathological image. The A and B are from the same patient from the fibrotic group. So A is at diagnosis, where we can see there are tight clusters of megakaryocytes exhibiting pleomorphism, and B is from the same patient who developed fibrosis on follow-up. This B shows there is increased fibrosis by as seen as streaming of cells. So and C and D are from the same patient from the cohort who didn't develop fibrosis. So C was at diagnosis, again there is tight clusters of megakaryocytes with pleomorphism, and D is the same patient on follow-up who didn't exhibit any fibrosis. You can compare the fibrosis between B and D. So on histopathological image there was not much of difference at diagnosis. So coming to the clinical parameters, so totally they included 77 cases in PMF progressing to fibrosis cohort, and 27 cases in PMF without fibrosis cohort. And coming to the gender difference, there was slight female preponderance in the group which didn't develop fibrosis, but however it was not statistically significant by Mann-Whitney u-test. It was not clinically statistically significant by Mann-Whitney u-test, and the age, the cohort who didn't develop fibrosis were relatively younger as compared to the cohort which developed fibrosis. So 56 years as compared to 61 years, which was also statistically not significant by independent t-test. So the total follow-up years was 475 years in group which developed fibrosis and 196 years in the group which didn't develop fibrosis, and the range was from 1 year to 17 years in the fibrotic cohort compared to 4 years to 14 years in non-fibrotic cohort. The mean follow-up was around 6.2 years in cases who developed fibrosis compared to 7.3 years in non-fibrotic cohort. So these details were not statistically significant. So coming to the lab parameters, so the first value is at diagnosis, the second value is during follow-up. We can see here that at diagnosis the hemoglobin was 13, which dipped to 9.6 in the PMF progressing to fibrosis cohort, whereas it was 15.1 at diagnosis, which dipped to 13.9 in non-fibrotic cohort. Similarly, there was a fall in leukocyte count from 12,000 to 11,400, whereas there was an increase in leukocyte count from 7,000 to 9,000. And again, platelet count was from 7 lakhs to 2 lakhs, and here from 10 lakhs to 5.96 lakhs. And the spleen size was also not significant. It was 13.5 centimeters at diagnosis in fibrotic cohort, which increased to 16.2 centimeters compared to 14 centimeters, which increased to 15 centimeters. So these clinical parameters were not statistically significant. So coming to the mean mutations at diagnosis. So here with the NGS panel, they analyzed the mean mutations per case. Here it was 1.65 mutations per case in the cohort which developed fibrosis, as compared to 1.19 cases, 1.19 mutations in the group which did not develop fibrosis. So this was statistically significant by independent t-test. So again, they also evaluated the clonal evolution on follow-up. So the clonal evolution suggests that there were new mutations which were acquired during the course, which was not initially present. So 30 out of 77 cases in the cohort who developed fibrosis had new mutations on follow-up, whereas only 3 out of 27 cases in non-fibrotic group developed clonal evolution during follow-up. This was also statistically significant by Fisher's exact test. So they also evaluated the gene mutations at diagnosis. So the gene mutations they checked by NGS was the driver mutations, which include JAK2, calreticulin, MPL, and wild type. Along with that, they also evaluated the CHIP mutations. So the CHIP mutations they have divided as rare mutations and common mutations. So first we will see about the gene mutation, driver mutations. So here we can see here there is not much of a difference between the driver mutations in both groups. It was 57.2% for JAK2 in fibrotic cohort compared to 59.3%, and 13% in fibrotic cohort compared to 11.1% for calreticulin type 1. Type 2 was 11.7%, 11.1%, and MPL was very less, around 4 cases out of 77, that is 5.2%, and here it was 3.7%. So the triple negative wild type was 11.7% in the fibrotic cohort as compared to 14.8% in non-fibrotic. So all these were somewhat equally present between both the groups. So all these were not statistically significant by Fisher's exact test. So this shows that both the fibrotic cohort as well as non-fibrotic cohort had a similar type of driver mutations. So coming to the CHIP mutations, first they evaluated the rare mutations. So the rare mutations included SRSF2, U2AF1, SF3B1, IDH2, EZH2. So the first three are that spliceosome complex mutations. The IDH2 is around the IDH2 is for the enzymatic neoplasia, and this EZH2 was epigenetic mutation. So this they evaluated. There was significant difference between the two groups. So you can see here 19 out of 77 cases had a rare mutation, whereas only none of the cases who didn't develop had a rare mutation. So this was statistically significant between these two groups by Fisher's exact test. So 13 cases had the SRSF2 was more common, and 13 out of 77 cases. So coming to the frequent ARCH mutations, here we can see here that both the groups had statistically insignificant difference, like TET2, DNMT3A, ASXL1. There was not much of difference between the two cohorts. So the mutational profiles of the cohorts included, like typical driver mutations included JAK2, calreticulin, MPL were detectable in almost 90% in both the cohorts, and the wild type included 11.7% in fibrotic cohort and 14.8% in non-fibrotic cohort. So the total number of mutations with the NGS panel was significantly higher in fibrotic cohort. It was 1.65 mutations per case compared to 1.19 mutations. So this was statistically significant. In particular, when MPN driver mutations were left out. So this data was not shown in the article. So coming to the rare mutations like SRSF2, U2AF1, SF3B1, IDH1 and 2, EZH2 mutations. So these rare CHIP mutations were found in 19 cases, that is 24.7% in fibrosis cohort, whereas they were completely lacking in non-fibrotic cohort. So the most frequent among these was SRSF2. So again, the commoner mutations which include TET2, DNMT3A, ASXL1 did not show difference between both the cohorts. So this was 16.9% in fibrotic cohort compared to 33% in non-fibrotic cohort. So when they compared the age difference, the frequent ARCH mutations were significantly present in older individuals than the younger individuals, like 65.5% of older patients compared to 58.2%. This was statistically significant in independent t-test. So time to fibrosis development in the fibrotic cohort, the median was 6.2 years with ranging from 1 to 17 years, and in JAK2 mutated cases the mean was 5 years. In calreticulin mutated cases the mean was 8.5 years. So the calreticulin mutated cases comparably have a smaller risk of rapid fibrotic progression, particularly when they compare that with triple negative samples. So for the triple negative cases, it was mean was 3.5 years to develop fibrosis. That was statistically significant. And there was no difference between the calreticulin type 1 mutation and type 2 mutation. So the mean was 8.8% versus 7.2 years between type 1 and type 2, and both of them were equally represented in the cohort. So between type 1 and type 2, there was not much of a difference. And the number of MPL mutated cases were only 4, and so they did not include in subsequent analysis. So this is the Kaplan-Meier chart for progression-free survival. So here we can see the percentage fibrosis in y-axis and follow-up in years in x-axis. So the green represents CALR mutation, JAK2 is represented by orange, and black stands for triple negative mutation. So here we can see here the patients who are having triple negative mutations develop rapid fibrosis as compared to JAK2 as well as calreticulin mutation. So the mean was 2.75 years in triple negative cases compared to 5 years and 8.5 years. So when we compare these three, all were statistically significant. That JAK2 versus calreticulin was statistically significant. JAK2 was versus triple negative is also statistically significant, and calreticulin versus triple negative. So this shows that the triple negative patient develop rapid fibrosis compared to JAK2, and the least one was for CALR mutated patients. So this is regarding the driver mutations. So they evaluated the progression-free survival for fibrosis for the CHIP mutations. So here the red represents the rare CHIP mutations, black represents all other mutations. So here we can see here the patients who are having rare CHIP mutations have a median of only 2 years for development of fibrosis as compared to the patients who are not having these rare mutations. So here the median was 7.25 years to develop fibrosis. This was statistically significant. So they further subdivided the other groups into the patients who are having frequent ARCH mutations and driver mutation alone. So here we can see the patients who are having rare mutations again had a median of 2 years to develop fibrosis. So this was statistically different between the patients who had a frequent ARCH mutation as well as the driver mutation alone. So even when we separate these two, statistically the patients who are having rare fibrosis did develop rapid fibrosis. So here the p-value was statistically significant when we compare the rare mutations with other two groups, and there was not much of difference between the driver mutation alone group as well as the frequent ARCH mutated group. So the clonal evolution in prefibrotic myelofibrosis, we have seen that the de novo mutations, which was not detected at presentation but emerging during the course of the disease, was found in 33 cases of the total 104 studied. So this was significantly more frequent in cohort with fibrotic progression. That 30 cases in fibrotic group had a de novo mutation compared to only 3 cases who did develop new mutations in the non-fibrotic group. So this was statistically significant. And the ASXL1, specifically like the de novo mutations of ASXL1 were more frequently encountered in the cohort with the fibrotic progression, 8 cases as compared to 0 cases in non-fibrotic group. But this was not statistically significant. When calculated per year of follow-up of total 475 follow-up years, there was one additional de novo mutation in 11.3 patient years in fibrotic progression group, whereas one per 65.3 patient years in non-fibrotic cohort respectively. So this shows that the patients who develop fibrosis have more frequent de novo mutations. So this is the NGS data where they have analyzed the mutations during follow-up. These are the driver mutations, rare mutations, frequent CHIP mutations, and additional mutations. So they have evaluated the different type of mutations, which include hotspot mutation, frame shift mutation, point mutation, and also the de novo mutation. So these were all the types of mutations which they analyzed during follow-up in fibrotic cohort. So since the patients who developed fibrosis did have increased mutation rate at diagnosis, so they evaluated whether there is a difference between the two groups for tumor mutation burden. So this tumor mutation burden was done using a commercial available assay, and it was done at diagnosis for 32 randomly selected cases, 20 from the fibrosis cohort and 12 from the non-fibrotic cohort. So this was not statistically significant by independent t-test. So the mean mutations was around 7.68 patients, 7.68 mutations in per megabase in fibrosis cohort compared to 6.85 mutations per megabase in stable disease cohort. So this was not statistically significant. So the prediction of fibrotic progression in individual cases remains a challenge, and reproducibility of prefibrotic myelofibrosis classification is limited. So in this study, the authors have informed that the disproportionate increase in the cases with fibrosis is explained by the retrospective nature, and the rebiopsy was done in most cases based on clinical progression. And recently, another study showed that the risk of fibrotic progression in polycythemia vera was associated with additional mutations in the genes, which are also frequently encountered in MDS cases. So again, here also the study is also similar in this case, and these genes have a potential to serve as the risk indicators when transplant is considered. So the clinical parameters at presentation between the two groups did not differ significantly from each other. The rare mutations like SRSF2, U2AF1, EZH2, IDH1 and 2 were exclusively found in the cohorts developing fibrosis, and in other studies they have mentioned that these genes have poor prognosis. Again, the ARCH mutations, which are not only restricted to the fibrotic cohort, it was also seen in the non-fibrotic cohort. So the de novo mutations of ASXL1, TET2, DNMT3A increase the risk of fibrosis than at presentation. So we have seen that 30 cases develop de novo mutations of these genes, and they develop fibrosis more frequently. So 31% of prefibrotic PMF cases demonstrated novel mutations which were not present at initial biopsy. So the additional uncommon chip mutations like SRSF2, U2AF1, IDH1 and 2, EZH2 is linked to fibrosis when present at initial biopsy. So in the current study, the allelic frequency of driver mutations were not associated with fibrotic progression. However, they did not mention the allelic frequency data in this article. And the mutation burden of the driver mutation also did not change during the progression. So among the 25 genes tested, there was higher number of mutations in the progressive PMF. However, there was no significant difference in the tumor mutation burden. So the study question is relevant, yes, and does the study add something new? Because the study adds something new because the mutations which results in fibrosis in PMF are studied in this case. And the merits of the study included included ample case of primary myelofibrosis which developed fibrosis. The limitations which I felt was the article did not include data regarding the IHC correlation, and the 25 gene NGS panel, they didn't mention what were all the genes which they evaluated in the 25 gene panel. So to conclude, not all chip mutation confer increased risk for fibrosis when demonstrable at presentation. De novo mutations which occur during the course of the disease, especially ASXL1, increases the risk for fibrosis. The rare chip mutations like SRSF2, U2AF1, IDH1 and 2, EZH2 at the time of prefibrotic PMF represent an independent risk factor for development of rapid fibrotic progression, the median of 2 years. So these mutations should be considered when planned for transplant. So that's about the first article. Any questions for the first article? So I'll move on to the second article for today. So the second article is CD33 expression on natural killer cells is a potential confounder for residual disease detection in acute myeloid leukemia by flow cytometry. So this was done by Ekel et al. And it was published in Clinical Cytometry in March 2020. So we all know that MRD assessment by flow cytometry in AML cases is gaining importance for providing patient-specific treatment. So usually difference from normal or leukemia-associated immunophenotype method like DFN or LAPE method is used for MRD detection. So this difference from normal can be confounded if the normal cell express unanticipated antigens. So previously in other studies they have mentioned that NK cells have been shown to express antigens like CD117 and CD19, and till now CD33 is assumed to be restricted in myeloid series. So the problem statement here was these authors were finding CD33 expression in the some of the NK cell population. So, and also the other problem is the NK cells may have a dim CD45 and increased side scatter which may fall in blast window. So this will be particularly problematic whenever we are estimating MRD assessment in AML cases which are CD34 negative and CD56 positive in those blasts. So the research question here was to determine the frequency of CD33 positivity in NK cells. So these were the two cases in which the authors have found the CD33 expression on NK cell. Here we can see here the blue represents the lymphocytes, the yellow represents the blast window. Here the NK cells are falling here, and the cyan represents the myelomonocytic cells. The NK cells are positive for CD7 and it is positive for 56. And here we can see the CD7 versus CD33. There are some amount of cells which are dimly expressing CD33 as compared to the blast here. So this was a case from post-transplant case. This was a peripheral blood sample. The second case was post-induction MRD sample. Here again the yellow represents the NK cells. So here also we can see there are some cells which are positive for CD33. So these two cases made them to evaluate the CD33 expression in NK cells. So flow cytometry analysis was performed in University of Washington hematopathology laboratory, and antibody panels was according to Wood et al. So they had 3 tubes with various antibodies here. So in addition to those antibodies, they have a separate antibody panel for NK cell immunophenotyping, which included CD7, CD2, CD13, 3, 56, 33, 38, 117, 16 and 45. So they included CD117, CD33 and CD13 along with the regular NK cell panel. So total they selected 40 samples, 12 from peripheral blood and 28 bone marrow samples. The inclusion criteria included the presentation should have either a myeloid neoplasm or when the cases are received for MRD assessment, and should have at least 5% of NK cells. So of the 40 samples, 11 were new cases. So these cases had predominantly cytopenia, 1 case of eosinophilia and mastocytosis, suspected mastocytosis each, and 29 cases for MRD assessment. 12 were post-chemotherapy at various time points, and 17 were at post-transplant at various time points. So 8 out of the 40 samples were found to have abnormal myeloid blast population at during evaluation, and 2 out of the 40 samples had abnormal CD5 positive B cell population. So at least 1,50,000 events were acquired for new cases and NK cell tubes, and 5 lakh events for MRD assessment. So the gating they followed was they followed a large gate for 45 versus side scatter to encompass the cases which are having increased side scatter, the NK cells which are having increased side scatter. So the NK cells were defined by 7 positive, 56 positive and CD3 negative. Monocytes and granulocytes were isolated using 45 versus side scatter gating. So to evaluate the non-specific binding, linked gating was used, so that 2 requirements were met. So firstly what they did was for each 40 cases in the primary experimental tube, the threshold to assign CD33 positive was set so that the CD33 was positive in less than 0.15% of negative control population. So they took the T lymphocytes as a negative control for CD33, and they adjusted a gate in such a way that less than 0.15% of events were positive for CD33. So this they linked with the NK cell gate. So I will show you the plot in the later slides. So and this was one internal control which they had. The other control was like for all the 40 samples they performed additional aliquot of each sample, and it was stained with a separate antibody cocktail consisting of same panel of antibodies, but they omitted 33, 117 and 13. So they did not include 33, 117 and 13 so that they can have a idea of the autofluorescence in that channel. So these are 3 different cases. So what they did was they had a separate negative control group for all the 3 tubes, which included the antibodies except CD33, 13 and 117. So here we can see here they have gated here in such a way that only 0.15% of cases are falling for positive in size 7 channel. So this was kept as a quality control, as an external quality control. And here for internal positivity, they took CD33 gate versus forward scatter in T lymphocytes. We can see here the CD3 positive cells and 7 positive cells. These are the T lymphocytes. So they took this gate and they took this events here for CD33 versus forward scatter, and they kept a cutoff of 0.15. So this they have linked with the gate which had CD33 in NK cell. So firstly what they did was they plotted the CD3 versus CD7. So this 7 positive and 3 negative stands for the NK cell. So the NK cell they further gated with 2 and 7 and 16 and 56. So this 1656 positive group, which is negative for CD3, is the NK cell population. So this NK cell population, they have evaluated the CD33 positivity in this events. So these two gates were linked to each other. So here we can see that less than 0.15% of positive events are seen here. So here this gate shows 11.9% of NK cells which are showing positivity for CD33. So similarly they did for the other cases. So they also calculated the MFI between the NK cells with monocytes and neutrophils. And to evaluate the effects of CD33 antibody clone specificity, 2 additional bone marrow samples for MRD analysis were for examination of NK cell. They added a different CD33 antibody clone. So initially they used a separate antibody clone. So now they wanted to know whether the NK cells were clone specific. So they included CD33 antibody of some other clone for two cases. So all the data compensation was done using the software developed in-house with the standardized evaluation for template across the samples. So in the initial clinical cases, apparent CD33 expression was observed in CD7 positive, 56 positive and 34 negative population, and these were falling in the blast window. So in the later, during the test samples, in the 40 samples, the total amount of NK cells averaged 5% of total WBCs and 19% of total lymphocytes. So out of these 40 samples, 7 samples had at least 5% of NK cells expressing CD33, of which the 5 cases are from bone marrow and 2 were peripheral blood samples. The CD33 NK cell population accounted for average of 11.4% of NK cells and 2.2% of total WBCs. So, and the CD33 positive NK subset consistently expressed bright CD2, CD56 and dim CD16. So the average CD33 expression on NK cell was dimmer than that of monocytes. The MFI ratio was 0.4 between them. The CD33 expression on granulocytes varied between patient samples. However, the CD33 expression of NK cells was similar to that of the granulocytes. The MFI was 1 between these two. And there was no statistical difference between the 2 clones of CD33 which they used. So in the sample 1, 12.9% of NK cell was positive with this clone, and in sample 2 it was 10.5% of the cases which are positive for CD33. So there was not a statistical difference when different clones of CD33 is used. In 2 out of the 7 CD33 positive samples, the NK cell fell into the blast region, and overall 11 cases the NK cells fell in the blast window. The CD33 expression in NK cell did not correlate with any stage of treatment. The different stages included like new cases, 17 cases after chemotherapy, 23 cases of post stem cell transplant. How this 33 expression did not vary between the stage of the disease. And only CD33 was significant. CD117, CD13 did not meet the criteria for positivity in NK cells. So CD33 positive NK cells, even though relatively infrequent, can be a potential pitfall while evaluating samples for MRD in myeloid neoplasms, particularly when CD34 is negative in those blasts. And NK cells are of 2 types. One is 56 positive, bright positive, and 16 dim, which accounts for cytokine production, and 56 dim and 16 positive, which is for cytolytic activity. So in this study, the cases which expressed CD33 was consistently CD56 bright and CD16 dim in bone marrow as well as peripheral blood sample. The study question was relevant. They wanted to know the CD33 expression in NK cells, and yeah, there are potential pitfalls in MRD assessment in AML cases, especially with CD34 negativity. The merits included the study was simple and provided a new insight in evaluation in MRD samples of AML cases. Limitations: the article did not correlate with morphological findings myelogram because including NK cell markers in all MRD cases may not be financially feasible. Again, the feasibility of adding NK cell markers to all cases is questionable. So to conclude, CD33 can be expressed in NK cell, which can be problematic whenever we assess for MRD in AML cases, because those cells fall in the blast window, and also CD34 is especially in CD34 negative cases, and addition of NK cell markers routinely in such cases should be ascertained in future studies with larger sample size. Thank you. Any questions for the articles which I should join? Any other questions? I would like to thank Jasmita ma'am for moderating this session. Thank you.
Copy और क्या है, ये लिंक भेज दिया। एंड संदीप जी कल भेजी थी ना आपने? तो वही
कल भी स्टूडियो 1 का ही था सर उनके पास।
हाँ ये अच्छा यही का था। वॉइस कॉल मैसेज भेज दिया। मास्क उतार लो, चेहरा दिखेगा। पता तो चल गया कौन सा बोलते हैं। यहाँ पर तो ऐसा तो ठीक है, कोई दिक्कत नहीं। रजिस्टर आपने हेलो ओके स्टूडेंट्स को डिस्ट्रीब्यूट कर दो हाँ हाँ अच्छा अच्छा ओके चलो थैंक यू गुड तो
सर अभी ओपीडी शुरू नहीं हुई टेक्नोलॉजी की चल पास चल
दूसरा का साइन लेंगे
साइड
good morning everyone hope all of you are safe and sound at home indoors in your hostel rooms so let us start the today's topic is toric soft contact lens its optics and fitting procedure. So in today's class we'll be talking about components of a glasses prescription, what is astigmatism in short, relevant to toric contact lenses, corneal versus lenticular astigmatism, with the rule versus against the rule astigmatism, incidence of astigmatism, its corrective options, and toric stabilization techniques like prism ballast technique, truncation, periballast technique, double slab off, and combination of techniques. And then we'll be talking about toric lens rotation assessment using Lars and Kaas rules, and then a review of simple transposition, and then vertex distance correction or compensation, then step by step toric contact lens fitting, and then toric contact lens fitting tips, followed by your favorite quiz. So if you look at this prescription, this is a glasses prescription, and it has got following components. This is spherical component minus 6.00, and this is cylindrical component plus 1.75, and cylindrical component always has an axis 90 degrees. So this is an example of a spherocylindrical prescription. So whenever there is a cylindrical number in a cylindrical power in a number, that means this prescription has got astigmatism. What is astigmatism? As you all know, astigmatism is a refractive condition wherein the point of object is not rendered as a point image by an optical system. Instead, there will be two meridians focusing at two different focal points, and they'll be having two different focal lengths. One meridian is focusing here and the other meridian is focusing here. So this is an example of a astigmatism. And if there is a astigmatism, it is corrected with cylindrical lenses. If you are correcting with the spectacles, if you want to correct astigmatism with the cylindrical lenses, you use contact lenses. Contact lenses that correct astigmatism are known as toric contact lenses. So based on the etiology, the astigmatism may be classified as corneal astigmatism or lenticular astigmatism. What is corneal astigmatism? In corneal astigmatism, the refractive cylinder is equals to the keratometric cylinder. If you take an example, minus 3.25 sphere with minus 1.5 cylinder at 180 axis. So here, as you can make out, the refractive cylinder is 1.5 diopters. So if you take out the keratometric readings, K1 is 43 at 180 and 44.5 at 90 degrees, and the difference between these 2 degrees is 1.5, again minus 1.5 diopter cylinder acting at 180 axis. So in lenticular astigmatism, the refractive cylinder is more than the keratometric cylinder. We'll see using the same example, minus 3.25 sphere, minus 1.5 cylinder at 180 axis. Again the refractive cylinder is minus 1.5 diopters. If you take out keratometric readings, K1 43 at 180, K2 43.5, 90. So there is a difference of only 0.5 diopters. So the keratometric cylindrical amount is 0.5 diopters. Refractive cylinder is 1.5 and keratometric cylinder is 0.5. So as per the formula, lenticular astigmatism, lenticular cylinder equals to the refractive cylinder minus the keratometric cylinder. So here the refractive cylinder is minus 1.5 and the keratometric cylinder is minus 0.5. If we put these values in the above formula, we get minus 1.5 minus 0.5, that equals to minus 1 diopter. So there is a difference of 1 diopter from the refractive cylinder and the keratometric cylinder. So as you can see here, the refractive cylinder equals the keratometric cylinder. So this is purely corneal astigmatism. If refractive cylinder is more than the keratometric cylinder, then this is lenticular astigmatism. It is very important because whenever there is a lenticular astigmatism, it's better to prescribe toric contact lenses than spherical contact lenses. Then based on regularity, astigmatism may be classified as with the rule astigmatism and against the rule astigmatism. What is with the rule astigmatism? In with the rule astigmatism, the vertical meridian is steeper. As you can make out here, the vertical meridian's power is 44.5 diopters and the horizontal meridian is flatter, 43 diopters. If you take out the corneal topography, you will find symmetrical bow tie pattern oriented in a vertical direction in case of with the rule astigmatism. So if you want to correct this type of astigmatism, you should always use minus cylinder. So minus cylinder would be acting as at 180 degree axis. So if you take the previous example, minus 3.5 sphere, minus 1.5 at 180. And on the other hand, against the rule astigmatism, the horizontal meridian is steeper as compared to the vertical meridian. In this example, horizontal meridian is 44.5 and the vertical one is 43. And in the corneal topography map, you'll get the horizontally oriented symmetrical bow type of pattern. So if you want to correct with minus cylinder, the axis of the cylinder would be at 90 degrees. So if you compare with the rule astigmatism, minus cylinder at 180, and in case of against the rule astigmatism, minus cylinder at 90 axis, 180 and 90. So what is the incidence of astigmatism? In studies, it has been shown like almost 60% of the refractive errors, they have some amount of astigmatism. Out of these, 50% of the cases, they have 0.25 to 0.5 diopters of astigmatism, and 25% of the cases will have 0.75 to 1 diopter of astigmatism, and another 24% of the cases will have 1 to 4 diopters of astigmatism, and only 1% of the cases were more than 4 diopters of astigmatism. So almost 99% of the cases will have up to 0.25 to 4 diopters of astigmatism. So which is the most commonest type of astigmatism? It is the most commonest type of astigmatism is the compound myopic astigmatism, and the least common is the simple hyperopic astigmatism. And with the rule astigmatism is 38%, and against the rule astigmatism is found in 30% of people, and oblique astigmatism 32% of prescriptions having astigmatism. Then what is the solution? You can correct astigmatism. What are the corrective options? The surgical options like LASIK, there are other surgical options as well, and the non-surgical options include spectacles. You may prescribe cylindrical number in spectacles, and also in contact lenses you can prescribe cylindrical number using either RGP lenses or soft contact lenses. Even spherical contact lenses, they correct the low amount of astigmatism, and sometimes spherical equivalent you may have to prescribe partially or complete spherical equivalent. As you all know, spherical equivalent is the what is the formula for spherical equivalent? The half of the cylindrical number is added algebraically to the sphere number. So that way you avoid the cylinder, and at the same time patient will not have that clear vision. Patient will have slightly reduced vision, both quantity wise as well as quality wise. And then also there are cylindrical contact lenses. When contact lenses are cylindrical, they are known as toric contact lenses. The cylinder may be ground on the front surface, then it is known as front toric. Then back toric contact lenses or bitoric contact lens designs are also available. So if there is a cylindrical number, there will have an amount of cylinder as well as axis of cylinder. So in spectacles, since spectacles are stable, they do not rotate, so the axis of the cylinder is stabilized. It will not move much. But our contact lenses, they keep on rotating because of the lid pressures. This video is not working. So the upper lid pressure while blinking, it pressures the contact lens in this direction, and the lower lid applies pressure towards medial side as well as up. So what will happen, this is exaggeration, slow motion of blinking. So there is a tendency to rotate a contact lens like this. This is the right eye of the patient. So for right eye it is anti-clockwise or counterclockwise rotation, and in case of left eye it is clockwise rotation. So contact lens has a tendency to rotate like this. This is because of the normal blinking process. So how to toric lens should, and lens should remain stable, axis should remain stable for stable vision. So what is the solution? The solution is axis stabilization. It is done by following methods like prism blasting, truncation, periblasting, double slab off, and combination of these techniques. So we'll discuss one by one slightly in detail. So what is prism blasting? In prism blasting, 0.75 to 2 diopters, prism diopters of base down prism is incorporated into the contact lens. As you can see, this is the cross section of a contact lens. Inferiorly there is a base of the prism, superiorly there is an apex of the prism. So because there is more mass inferiorly, there will be gravity, but gravity will have minimum effect in stabilization of the axis. But there's one more principle, on that basis lens remains stable. This principle is known as watermelon seed effect. So if the moist rounded off wedge is squeezed, you must have noticed when you squeeze in between the fingers like this, the watermelon seed, it will go in a projectile motion, and the front portion would be the base of the seed of the watermelon. So in the same principle it works. Then what is truncation? In truncation, the lower portion of the contact lens is removed from the prism blasted lens, and generally it is no longer carried out nowadays. Sometimes this method is employed, especially in RGP lenses, when everything else fails to stabilize the lens rotation. Another method is periblasting. In this technique starts with a minus carrier. So in the central portion there will be appropriate power, refractive power, and the carrier portion would be minus carrier. So it is kind of lenticular lens. To create a base down effect, the superior carrier portion is slabbed off. It will be thinner as compared to inferior portion. So this allows the periphery to position comfortably under the upper lid. So what is double slab off? This is also known as dynamic stabilization. In this method, the superior and inferior zones are slabbed off. So the net effect would be base up prism in the superior portion, base down prism in the superior portion, and base up prism effect in the inferior portion, and these two portions will be covered by the lid. So whenever lens tries to rotate, the blinking action brings the lens back to its original position and original stable position. That is why it is also known as dynamic stabilization method. Then here is the summary of toric contact lens stabilization methods. Prism is the cross section. Inferiorly the lens is thicker as compared to superiorly. Base down prismatic effect, and if you cut down lower portions, then it becomes the truncation method. Then if you cut down the slab of prisms superiorly and inferiorly, then it becomes the slab of technique. And in periblast technique, the central portion, there will not be any prismatic effect. Prismatic effect would be produced in the peripheral portion, so there would not be any prismatic effect acting in the central portion. So how to assess? In spite of all these techniques, there will be slight rotation of the axis always. So how to assess? To assess, see, if you look at the face of a clock, a circle has 360 degrees and there are 12 clock hours. So 360 divided by 12 equals 30. So any clock hour, like from 12 to 1 or 2 to 3, would have 30 degrees rotation, 30 degrees difference. So 30 plus 30 plus 30, 12 times, then it becomes 360. So likewise, contact lens, toric contact lens, some companies, they have marks, laser marks. Like some companies, some brands, they have mark, laser mark at the 6 o'clock. Some companies, some brands, they have 9 and 3 o'clock positions and 6 o'clock positions. Some have only 9 and 3 o'clock positions. Some have 6 and 12 o'clock positions, and some have 5 o'clock, 6 o'clock and 7 o'clock positions, and others have 5:30 o'clock, 6 o'clock and 6:30 o'clock. So if the markings are 5, 6 and 7 o'clock, this amounts 30 degrees this side, 30 degrees that side. Here it is 15 degrees. So, and these marks are not axis marks, these are orientation marks. Do not get confused with the refractive axis of the cylinder. So these are the real pictures. So there is a mark at the 6 o'clock here, and there are 3 marks out here. This is 6 o'clock mark, this is 5:30 o'clock mark, and this is 6:30 o'clock mark. So if lens rotates this much, this would be 15 degrees rotation. And in this picture, there is a mark at the 9 o'clock position. So there are axis rotation rules. There are 2 rules. There is one rule you can remember as LARS or CAS. LARS stands for left add, right subtract, and CAAS stands for clockwise add and anti-clockwise subtract. As you can see in this picture, if this lens rotates to this side, that is your left side, then you need to add the same amount of rotation, same axis, to the original glasses prescription axis. And if the lens rotates to your right, not to the patient, your right and your left. So if patient rotates to your left, always add the same amount to the glasses prescription axis, and if it rotates on the right side, then you need to subtract the same amount of rotation axis to the original glasses prescription, as you can make out here. So let us take an example to understand this concept better. Contact lens trial lens power is -1, -3 sphere, -1 cylinder at 90 degree axis. And when this lens was placed in the eye, this lens rotated 10 degrees to the left, that is clockwise, your left hand side. So then the lens stabilized at -3, -1 same power at 80 degree axis. As you can make out, instead of 90, it stabilized at 80. So this is rotation towards your left. So as per Lars rule, left add, you need to add this 10 degree to the original prescription. Then your prescription becomes -3, -1 at 100 instead of 90, since there was a rotation of 10 degrees to the left. So when you prescribe this number at this axis, then when the final lens will come, it will stabilize at 90 degrees if you prescribe at 180. Then how to measure this location, lens rotation? So to measure, you may take help of these marks, laser marks, 6 o'clock, 9 o'clock, or whatever type of marks that we discussed are present. Then what are the methods? You may use slit lamp beam, like you can make out there's a slit lamp beam and there's a rotation mark here. So there's a rotation of 10 degrees. This is clockwise rotation or left hand side rotation. So you need to subtract this 10 degrees left and right subtract. So you need to add this 10 degrees to the final prescription, to the original glasses prescription, to get the final prescription. Another method is by using protracted scale on the eyepiece of a keratometer. From here you can read out the rotation angle. And the simplest method is the combination of trial frame and the streak retinoscope. You can align the streak to the mark and then you can read out the rotation on the trial frame itself. So let us revise the simple transposition. So there are 3 steps of simple transposition. So this is done to convert the glasses prescription from one cylinder form to the other cylinder form. So like in contact lenses, you always require in minus cylinder form. So if your prescription is in the plus cylinder form, you need to convert it to the minus cylinder form. So how will you convert? By using simple transposition. So to get new spherical power, you algebraically sum the spherical as well as the cylindrical powers. To get the cylinder sign would be opposite, like if it was plus sign before, now it is minus sign, and the cylinder power remains the same and the axis would be perpendicular. So 90 degrees apart from the original axis. Let us understand this concept with the help of examples. If you take this example, spherical is plus 2 diopter sphere plus 1 diopter cylinder at 180 axis. If you want to convert this prescription into minus cylinder form, here it is in the plus cylinder form, to convert into minus cylinder form, so new sphere would be algebraic summation of these two parts. So plus 2 plus 1 plus 3 diopters, and the sign of the cylinder would be opposite. That is why you are performing this simple transposition. So plus 3 sphere and minus sign, and sphere cylindrical amount remains the same. So plus 3 sphere minus sign, 1 diopter, and axis would be perpendicular. So perpendicular to 180 axis means you need to subtract 90 degrees. 90 degrees away from the 0 or 180 axis would be 90 degrees. So your final transposed prescription would be plus 3, adding these two values, then opposite sign, minus instead of plus, then same amount of cylinder and axis perpendicular. So plus 2 minus 1 at 180 becomes plus 3 minus 1 at 90 degrees in the minus cylinder form. Let us discuss another example, minus 5 minus 3 at 90. So if you want to convert this into plus cylinder form, new sphere would be algebraic summation. So sphere would be minus 8, the sign of cylinder would be opposite, minus plus instead of minus, and the amount of cylinder same, and the axis perpendicular. Another example, +3 -1.5 at 90 degrees. So algebraic summation of these two values, you get +1.5. So +3 -1.5 equals +1.5. The sign of cylinder opposite, plus from minus, amount of cylinder remains the same, and axis perpendicular. The last example, -4 -2.25. If you add these two values, you get -6.25. The sign of cylinder opposite, and the amount remains the same, and axis 70, and you add 90, then you get 160. So for -4 -2.25 at 170, you get -6.25 plus 2.25, axis at 160 degrees. So vertex distance compensation, this is done using optical cross, and also there is a formula. So vertex distance is the distance between the back surface of the lens and the front surface of the cornea. So formula to calculate vertex distance is FCL equals FSPEC divided by 1 minus D into FSPEC, where FCL is the power of contact lens, Fspec is the power of spectacle, power at the spectacle plane here, and 1 minus D is the vertex distance. This distance should always be in meters. So if the spectacle plane is 12 millimeters, it is measured in millimeters, but in formula it should be in meters. So for 12 millimeters, you will put the value here 0.012 meters. So more often people do this mistake, and they will end up with something else. So always keep in mind how to convert millimeters into meters. So what is the importance? When you refract, you get refractive number at the spectral plane, but you are going to prescribe contact lens. So because the position of lens with respect to the eye, the effective power of the lens changes. Like lens will have different power at this this distance, and it will be different on the cornea. So to calculate this difference, this vertex distance correction is utilized. So, and you should always remember rule of thumb, like for minus powers, contact lens power will be less, because when you move minus lens closer to the eye, its effective power increases. So for minus lenses, like for myopes, if there is a patient is using minus 10 diopter spectacles, then its contact lens power would be like 9.25 or 9.5. And for plus lenses, the contact lens power would be more. If the patient's glasses prescription is plus 10 diopters, the contact lens power would be more than 10, like plus 11 diopters. So we can understand using optical cross. This is a cross. So if you want to make a spherical cross, in a spherical cross, both the meridians would have the same power, like -2 in the vertical meridian and -2 in the horizontal meridian. So if you make a cylindrical cross, then one axis would have a power, like for example -0.5 power in the vertical meridian, and the other meridian would have a 0 power, because cylinders have power only in one meridian, and in the axis meridian there is no power. So if you want to add this sphere with cylinder, what you get along the vertical meridian, you get -2 added with -0.5, you get -2.5. In the horizontal meridian, -2 added 0, then you get 2. So this is a spherocylindrical cross. So vertex distance correction should always be done in all types of contact lenses whenever powers are more than or equal to 4 diopters, plus or minus 4 diopters. Up to 4 diopters, up to 3.75 diopters, you need not to do any vertex distance compensation. If the power exceeds this limit, that is 4 diopters or more, then you need to calculate the vertex distance compensation. So, and if you talk of toric soft contact lenses or toric lenses, this compensation is done along both the meridians separately. Okay, so let us take an example like spectacle prescription is -4, -2.75 at 180. Let us put these values in this cross. So minus the lower number would be the this, so minus 4.75 along the horizontal meridian, and the addition of these two vertical meridian would have minus 7.5 diopters. So this is the cross. So either you can calculate using, if you go back, using this formula, or there are correction tables are also available. So you may refer to these tables. These are easily available on internet, or manufacturer, contact lens manufacturers also provide. So for how to check in the conversion table, this is the conversion table. So power is 4.75, 4.75, here it is 4.75. The minus cylinder minus power would be minus 4.5. So the vertex correction for minus 4.75 would be minus 4.5, and for minus 7.5, minus 7.5 diopter, minus would be minus 6.87. So we do not have 6.87 diopter lens. We have lenses in only 0.25 diopter steps. So we can take the nearest to 0.25 diopter. So minus 6.75 you can take. So minus 6.75. So for sphere, for horizontal meridian, minus 4.75 becomes minus 4.5. Along the vertical meridian, minus 7.5 becomes 6.75. So if you convert this cross into prescription form, then lower value would be the spherical, and the difference of these two value would be amount of cylinder and the axis that is parallel to the lower power. So minus 4.75, minus 2.75 at 180, this is the spectacle number, and the toric number at the corneal plane or the contact lens number would be minus 4.5, minus 2.25 at 180 degrees. So you can make out there is a slight reduction in sphere and cylinder also. Okay. So coming on to the steps of soft toric contact lens fitting. As you all know, the design of a contact lens. So in the front surface, if there is a one curvature, then this type of lens is known as single cut lens, and if there are two curvatures, then the lens becomes the okay. And then on the posterior surface, The central curve is known as the base curve. Then there are peripheral curves. The first curve is the first peripheral curve, and then the second peripheral curve or third peripheral curves, depending upon the number of curves that we have. So central curve or the base curve, this matches the front surface of the cornea, and its radius of curvature would be less as compared to these two peripheral curves. So first peripheral curve will have more radius of curvature as compared to base curve, and the peripheral curve would have the most radius of curvature. So this would be flatter. Why this type of design? Because your cornea is not perfectly spherical. As you move from center towards periphery, the cornea flattens. So to conform the corneal surface, you need to flatten the lens towards periphery. So on the front surface, I was recollecting the term. If there is single curvature, then it is monocut lens. If there are two curvatures, then this would be known as the lenticular design. Okay, so what routine we follow? So first we select the patient. There is a selection criteria. All patients cannot be fitted with toric lenses. Then we select the trial lens. Like in spectacle number, there are three parameters: the spherical, the cylindrical, and the axis of the cylinder. Likewise, in contact lenses also, there are three parameters: base curve, this is base curve, the posterior curvature, and the power of a contact lens, and the diameter of a, or the overall diameter of a contact lens. At least minimum these three parameters you need to supply to the manufacturer, contact lens manufacturer. Then the trial lens is selected based on these parameters, and then lens is inserted into the eye, and patient is made to wait for 15-20 minutes, and then the contact lens fit assessment is done. So patient selection, in which patients toric soft contact lenses are fitted. So toric lenses are fitted to correct astigmatism as low as even 0.75 diopters. Astigmatism may be corrected with toric soft contact lenses. Up to 6 diopters, up to 3.5 to 4 diopters lenses are easily available. Only a few companies they make up to 6 diopters of cylinder, because in the incidence you saw 99% of the patients they'll have only up to 4 diopters of astigmatism. But like in irregular corneas, the higher amounts of cylindrical number also exists, and such high amount of irregularity and the higher cylindrical number is corrected using the specialty lenses, not with the lenses, the simple toric lenses which we are discussing today. So also to correct the corneal as well as lenticular astigmatism. Corneal astigmatism easier, but particularly if there is a lenticular astigmatism, then these lenses are best suited. And for better vision, as the spherical equivalent may not give the patient the best vision, so if you correct sphere and cylinder both, like if you give spherical equivalent in spectacles, patient would not have good quality and quantity of vision. So if you prescribe sphere and cylinder both in glasses, patient's vision would be much better, both quality wise, number of lines that patient would read, as well as the quality wise also. So quantity and quality of vision improvement happens when you prescribe both sphere and cylinder. The same thing is applicable with the contact lens as well. So if there is a high sphere to cylinder ratio, and if there is a intolerance to RGP lenses, some patients they are poorly tolerant to RGP lenses. Such patients may be switched over to the soft toric lenses. What are the advantages of soft toric over RGP lenses? Soft toric lenses are more comfortable, they are much easier to fit, and the lens cost is also low. And these soft toric lenses are easily available. Even you can maintain an inventory stock, so immediately you can dispense the lens. Whereas in case of RGP lenses, you need to order the lens, and manufacturer takes 1 or 2 days or sometimes more to get the lens to your office, delivered to your office. And also toric soft lenses are best suited for occasional wearers because there is no adaptation involved. So what are the preliminary examinations done before fitting any type of contact lens? Proper history is taken, then visual acuity assessment is done, both in without glasses, with correction, as well as with contact lenses and with pinhole. And the refraction is done, both objective refraction as well as subjective techniques. Objective refraction either using autorefractometer or retinoscope, and subjective refraction, all the subjective refraction techniques like cross cylinder, clock dial, and in the end the binocular balancing is done. Then binocular vision assessment like extraocular muscle balance is assessed, and then torchlight examination or external examination is undertaken, followed by slit lamp examination to rule out any contraindications to the use of contact lenses. Then keratometry or corneal topography is performed. Then HVID or horizontal visible iris diameter measurement is undertaken, and then tear film evaluation is done using different dyes like rose bengal or fluorescein dye. So both the quality and quantity of tears are assessed, and it is and also tests for dry eyes are performed. And then finally the dilated fundus examination is done, because most of such patients are myopes, and for myopes dilated fundus examination is mandatory, preferably every 6 months to 1 year. So if you are planning to perform in the same visit, then this should be done towards the end of the examination after assessing the contact lens fit, or you may defer the contact lens fitting to the next visit. So basically there are two methods of fitting soft toric contact lenses. Empirical method, where company provides the nomograms. As per the nomograms, you may order the power, and the diagnostic fitting. Diagnostic fitting is more scientific, and we'll be discussing about this method in a bit detail. So what are the minimum parameters? As we discussed before, base curve. Base curve is measured in, the unit of base curve is millimeters or diopters, depending upon what type of trial set you have, mostly in millimeters. And the power of a contact lens in diopters. OAD is overall diameter or diameter of the soft contact lens, soft toric lens. It is measured in millimeters scale, and whatever HVID you get, you add 2 to 3 or 2.5 millimeters to the HVID to get the overall diameter of a soft toric lens. So how to finalize the power? You should perform a fresh refraction, both objective and subjective, and then convert the cylinder power into minor cylinder form by using simple transposition that we discussed just now. Let us take another example. If the spectacle prescription is -6 plus 1.75 at 90 degrees, as you can make out, the cylinder is in the plus cylinder form, So you need to convert this into minus cylinder form. So the new sphere would be algebraic summation. So if you sum up these two values, you get minus 4.25. The sign of cylinder would be opposite, minus in place of plus. Then the power of the cylinder would be the same, and the x is perpendicular. So for minus 6 plus 1.75 at 90, you get minus 4.25 minus 1.75 at 180. Then you measure the base curve. For that, you need to perform either keratometry, manual or automated, or corneal topography. From there you can take the SIMK values. And to the flattest meridian, there would be two meridians, the flattest meridian and the steepest meridian. To the flattest meridian, you add 0.8 to 1 millimeters to get the base curve of the soft contact lens. So if you get 7.50 millimeters of corneal curvature, the flattest meridian, then you add 0.80 millimeters, you get 8.30 millimeters. So this would be the base curve of the soft toric lens that you'll be trying. So then vertex distance correction or compensation is made to get the power at the corneal plane out of the spectacle reflection or reflection at the spectacle plane. So it is done for sphere and cylinder separately using optical cross. So for this example, so for horizontal meridian, it is at the 15 degrees. For minus 3, there is no need to do the vertex distance compensation because it is less than 4 diopters. So this remains the same. For vertical meridian, if you go through the vertical distance correction table, for minus 6 you get minus 5.5. So the original prescription or glasses prescription was minus 3 sphere, minus 3 cylinder at 15 degrees. Then contact lens power you get minus 3 sphere same, and cylinder instead of 3 you are getting 2.5 at 15. So normally unqualified opticians, what they do, they directly prescribe this number as a contact lens. So what will happen, you will be over correcting the cylindrical number, and patient will have not only unclear vision, will have strain and other problems. Then to decide about the overall diameter of a lens, you measure the HVID as discussed earlier also in millimeters. So either you take optician's ruler to measure the HVID, or there is a reticle, and also there is a reticle, there is an eyepiece in the this is an accessory in the slit lamp, so you can replace with regular eyepiece this is uni-ocular, and then you take measurement in millimeters. So whatever measurement you get, you add 2 millimeters to get the soft toric diameter of a soft toric lens. Then choose an appropriate toric trial lens. So based on these base curve, oral diameter and power, so your trial lens should be as close to the spectacle prescription as possible, because you will not have all the like desired power. The best is if you have the exact power, you try the exact power, but most of the times you don't have exact power. So your trial lens should be as closer to the prescription of glasses as possible, and then make the patient to sit in the waiting lounge for 15, 20 or 25 minutes depending upon the patient's sensitivity to the lens, and then you assess the fit. Fit is assessed keeping in mind the coverage on the cornea, centration of the lens on the cornea, movement of the lens when patient moves his or her eyes in different directions, and comfort of the level of the patient. So for a good fit, full corneal coverage is expected, like this edge should not touch the limbus. Then there should be good centration. There should be only 0.3 to 0.5 millimeters of movement on blink. And if you nudge the lens, or if you you may do the tightness assessment. So if you push the lower edge of the lens to dislocate the lens, and that way you assess the tightness. 40 to 60% tightness is optimum. This is a subjective kind of assessment. In a tight fitting lens, this lens would be well centered, and initially patient would be comfortable, but after some time patient might feel some pressure or tightness on the eye, and there will not be much movement, and patient will be the lens will be slower to return back to its original axis if intentionally mislocated. Whereas in case of loose fitting lens, there will be excessive movement of the lens, then there will be poor centration of the lens, like as you can make out, this is getting decentered, and there would not be a stable orientation. So then you assess the rotation of the axis, then for final axis finalization, you use Lars or Cass rule, left add, right subtract. If you take this example, the original prescription is -3, -1.75, and at 180 degrees. When the patient was, after settling of 15-20 minutes, when the patient was assessed, then this lens rotated towards right, show right hand side. How much? 20 degrees by 20 degrees. So patient stayed at, instead of 180, at 20 degrees. So this was the par. Then as per the Lars rule, left add, right subtract. In this example, it is moving towards right, then you subtract this much amount, 20 degrees, to the original axis. So if you subtract 20 to 180, you get 160. So final lens you order would be -3, -1.75 at 160, and when the final lens would come, it will settle at 180 degrees. So then final desired power you would be getting -3, -1.75 at 180 axis. So let us take examples, like spectacle power is -6, -3, 180, vertex distance correction, -6 becomes 5.5, -3 becomes 2.5, 180. Then trial lens, you have you do not have exact lens, but you have trial lens -3, 1.25 at 180. Then on assessment, you find that this lens was rotating towards right hand side 15, so you need to subtract from this. So 180 minus 15, you get 165 axis. Then your final prescription would be -5.5, -2.5, and 180 minus 15, then you get 165. Another example, spectacle prescription -1, -3 at 120. Trial lens that you got -2, -0.75 and 90, quite different, but using this trial lens also you can finalize the power. So it is rotating right hand side by 10 degrees. So it was 120, right subtract as per the Lars rule. So you subtract 10 degrees from 120. So the final power would be -1, the same, 3, 2.75 after the vertex distance correction, and and the axis would be 120 minus 10 degrees of rotation, 110. So to summarize, soft toric contact lens fitting, step 1, perform the refraction, write the prescription in minor cylinder form, then perform the keratometry and add 0.5 millimeters to the flattest meridian to get the base curve of the soft toric contact lens. Then perform the vertex distance compensation for spherical and the cylindrical parts in both the meridians separately. Then choose the toric trial lens as close to the spectacle prescription as possible, and then assess the fit, keeping in mind the coverage, the centration, movement, and the comfort, and then assess the rotation for axis finalization using the Lars or the left add right subtract rule. This is a little video. No, it's not working. So let us, these are the references. Jump to the your favorite quiz. So take the correct par. You may answer 1, 2, 3 or 5th option in the chat box. So for this situation, there is a movement towards left, then you need to subtract the same, add the same amount. The prescription is 170. If you add 15 to 170, how much you get? Answer. Let me answer then. It would be 5 degrees. Then how many millimeters are added to HBID in order to get the overall diameter of a soft lens? Right, it is 2 millimeters. 2 to 3 millimeters are added. Here is a homework for you guys. You need to convert. These are the examples of simple transposition, and then reply me either on WhatsApp or in the chat box. Then how many millimeters are added to the flattest K in order to get base curve? Yes, you are right. It is 0.80 millimeters. Then vertex distance correction is done for powers which are more than or equal to 4 diopters, plus minus 4 diopters. Thank you for attending this online class. Stay indoors, stay safe, and study well. That's all for today's class. Thank you.
Bill.